blood investigation, lab investigation, everything inside the sheet. اوكي. انا هقرا لك كده. هو دي اول كول. You call a consultant in charge Mr. Wolfson to tell him about a case done by Mr. Browse. هو in England it's not necessary to call the same consultant. You call the consultant in call. So you call him about 75 years old lady with a background of chronic obstructive pulmonary disease with mild left ventricular failure, underwent a mastectomy and axillary clearance for breast cancer 2 days ago by Mr. Browse. يبقى هي operation done by Mr. Browse and you call Mr. Wolfson because Mr. Wolfson is a consultant in charge today. Post-operative, she developed axillary discomfort with the shortening of breath. 500 cc of blood come out from the suction drain. The patient is due to go to home tomorrow, but due to this complication, she will postpone. So the patient is planned to discharge tomorrow, but during this complication, we post her for discharge. Okay?
Okay.
All right. Her daughter went to take her home to her home, which is Bungalow. Bungalow means countryside, like countryside or rural area, 60 miles away. 60 miles is about 100 kilometer from the hospital. She was pursued that her mother would be pissed with her. You have spent at least at last 20 minutes trying unsuccessfully to explain to her daughter that the discharge today is not for the patient's best interest, especially since her home is away from hospital. The daughter is very determined and want to have her away. She is a school teacher out of home in the morning, and her husband work also, and 2 teenage daughter in the secondary school. All right. So this is the script, but the scenario itself, the personal history, they start from the past. The personal history is the patient file or patient sheet. So Mrs. Anne Mary, 75 years old, a woman with background of chronic obstructive airway disease and left ventricular failure, suffered from lump in upper outer quadrant of her left breast, firm in consistency, 4 by 3 centimeter, attached to the skin, no bodorange, no tethering, no buckling. So this is the past history or admission sheet. Mammogram, macrocalcification, irregular mass, fine needle aspirated cytology, C5 mean malignant cell, CT, thorax, abdomen, and pelvis are normal. Bone scan is normal. Operative detail, the surgeon is Mr. Browse. The anesthesia is Dr. Ruben. Procedure is left mastectomy, axillary clearance for the breast. Connected to suction drain were inserted, one in axilla and second in the breastplate. Post-operative follow-up, first day normal vital sign, second day the patient developed axillary discomfort with shortening of breath and 500 cc of blood come from the suction drain in the axilla. A blood sample is taken for hemoglobin level. Follow-up, plan for exploration of axilla and secure the bleeding. Full blood count, you can see, just to take a look. If you have any notes, you can write in your paper.
Okay.
Okay, after that, they have arterial blood gases. Also, you can write a note in your paper if you found any diagnosis. Sometimes it is normal, can be normal, no problem.
Okay.
Chest X-ray is done. As you see here, mastectomy is done in the left side, and the chest X-ray is also look normal. Okay, that's it. This is what we have. Okay. So, what shall I do now? I just bring the presentation. All right. So, of course, you are in the station. You have 9 minutes in the first station or preparatory station. After that, you come to the to call the consultant. All right. When you are ready, I'll just show you the presentation. Okay. All right. So you can start. You either we give you a name, or you can write your original name, no problem.
Okay.
Okay, so you can, if you're ready, you can start.
طب الجوب بتاعتي مثلا ريجسترار او كده او اي حاجه.
No, it's written here, you are SHO, houseman.
اوكي.
Okay, all right. Of course, is what is written, usually is written either CT. CT means that core training. Core training means that you are a young doctor like houseman or senior house officer. Okay. All right. So you're supposed to be SHO working with Mr. Browse. You can start, by the way.
Okay. Hello.
Hello,
I'm
yes.
Dr.
Okay, so
Muhammad.
first in exam, you just write your number like I am number, your candid number. Don't forget that. After that, you can start. Go on.
Hello.
Yes, hello, yes.
I am Dr. Muhammad. I'm the SHO working with Mr. Browse.
All
Can I
right,
confirm
okay. Yes, I
Can I
am Mr.
confirm I'm
Wilson.
speaking?
Yes, I am Mr. Wilson, yes.
So, Mr. Wilson, I'm calling to offer to present a case, which is Mrs. Janice. She is 78 years old, with a background of COPD and mild left ventricular failure. She had mastectomy with axillary clearance 2 days ago for breast cancer, and now she is presenting with shortness of breast, and the drain in the axillary region is draining 500 cc.
Okay.
Now her
So
daughter
is
wants.
this is my patient or not? Not my patient.
Yes.
No, it is my patient or
No, it's a patient of Mr. Browse.
okay, so why you call me?
I because
Okay,
you are
so
the consultant on call today, sir.
yes, okay, thank you. All right, okay. All right, so can you tell me about the patient or what is the problem? How can I help you?
I'm calling you for the patient, Mrs. Janice Green. She is 78 years old with a background
Yeah,
of COPD.
yeah, you
She had a
mentioned that
mastectomy.
before. What is the problem now?
The problem in the second day post-operative, the patient developed shortness of breath, and the drain from the axillary region drained about 500 cc of fresh blood. Now her daughter wants to take her home, which is 60
Okay,
miles
so
away.
doctor, is the problem is the blood is coming or her daughter? You call me because the blood is coming or her daughter need to take her?
I'm calling you for both.
For both.
Because
Okay,
of the
so
blood.
start by one. We start by her daughter. Okay. So is this patient have a capacity to make our decision or not? Is this patient have a capacity to make our decision? She is oriented, she is okay or not?
Yes, she is oriented.
Yes. So if this patient is oriented and have capacity to consent or to speak to you, so we don't care with her daughter wishes or her daughter what her daughter need. Are you agree with me?
Agree with you, sir.
All right. Okay. So this patient or her daughter, or maybe the patient need to be go to discharge. All right. So you mentioned that this patient have bleeding. Okay. So what is the cause of this bleeding? What you think this bleeding coming from?
And the view of the fresh blood in the brain and
Yes,
the
I know
source of
that you
breast.
have blood in the drain, but what from
Possibly
where this blood come?
there is hemorrhage in the one side.
Yes. What is the cause of this hemorrhage usually?
This may be an arteriovenous malformation.
No. Don't think more
Injury.
much. It is just to be can be a slept lecture or unsecure lecture or something like that, which is common.
Slip
Don't
declips
think
or
more
injury to
extreme.
vessels.
So this is hemorrhage. What is this condition called? You mentioned this patient have swelling in axilla and hemorrhage. So what's this condition called? If the patient have swelling after any surgery in axilla or any wound, what we called it?
We call it like a differential diagnosis of the swelling.
Up to you. I don't know, but what
It
is
may
this
be
condition
lymphedema,
called?
it may be axillary vein thrombosis. or
No,
bleeding?
we don't ask
Hematoma.
you.
Hematoma.
It is just
Hematoma.
hematoma or seroma.
Just
Think simple.
hematoma.
It is hematoma or seroma. So is this patient you mentioned have a bleeding of 500? So what you did for her?
For her, I I booked the blood product. I did firstly. I gave her resuscitation fluids, and I booked the blood products for her. Also, I will order a follow-up
Okay, okay,
complete
just
blood
one by
count.
one. So what is hemoglobin level?
Her hemoglobin is 90 now.
9 now,
It's
but in the
dropping.
past it is
Drop
8. So what is the indication of giving blood to the patient usually in England?
below 8.
Below 8. Okay, so you make a hemoglobin, you give her blood. And you plan to evacuate the hematoma tomorrow, I think. That's true? Okay,
True.
so you mentioned this patient have shorting of breast. So what you do for that?
For shortness of breath, I put her on oxygen.
Yes.
Uh, uh,
Okay, you
and
put in oxygen.
I will arrange for CT pulmonary angio
Okay,
to
no,
exclude
just
the
one by
pulmonary
one,
embolism.
doctor. Usually the answer in the presentation in your sheet. So what we did in the sheet is your answer. What you did already in the sheet.
Uh, in the sheet,
If you remember the
chest
sheets, we
X-ray,
have
chest
chest
X-ray,
X-ray,
chest X-ray was
arterial
done and
blood
was normal,
gases.
and arterial
So
blood
chest
gases
X-ray is normal, arterial blood gases is
showed respiratory alkalosis, suggesting pulmonary embolism.
the doctor. You
Maybe
you you see the blood gases.
and
You see the
respiratory
blood gases.
alkalosis, wallah,
No, it is normal.
normal. Okay.
I just make it again, just to make it again, just to make it again. All right.
Sorry.
You know that I think you have an idea about the case before, so this is the easy way to fail. You can see it now. Okay, I just share again.
Okay.
Th- Okay, this is the blood gases.
This
What
one
is
is
your
not.
opinion?
it's borderline normal بس أنا على فكرة مش عشان عارفها قبل كده السي او 2 شفتها 34.7
All right, but
آه،
يعني مش
بس يعني هي
يعني
دي اللي أنا
with the
شفتها.
normal يعني. Don't be
اوكي ودن.
expected something because we can change it at any time. So arterial blood gases, chest X-ray is normal.
اوكي. الو الو.
So yes, I have. So why you mention it is pulmonary embolism, doctor?
Because the patient is old age and post
Okay.
surgery.
Doctor, if you have this attitude in exam, you failed. You know why?
No I don't know.
Okay.
ال
First,
مش
this is
trust يعني.
patient how many days after surgery?
2 days.
2 days. Is pulmonary embolism can occur after 2 days?
No.
Okay. So don't say something you can put you down. All right. So because the most of the students say pulmonary embolism. Okay. So the next it is not pulmonary embolism. So the next question, can pulmonary embolism occur in the third day in some patient, not in this patient?
Yes, in orthopedics after
In orthopedic patient or if patient is already bedridden for long time. Okay.
yes
All right.
yes
So this is
okay.
the answer. So it is not pulmonary embolism. So you ask for chest X-ray, arterial blood gases. So what you ask is what is written. And this is not pulmonary embolism. Pulmonary embolism need 10 days to happen. But sometimes if the patient have fracture or something can have pulmonary embolism. All right. So suppose it is pulmonary embolism, what investigation we need to do?
I need to do a D-dimer CT pulmonary angio. I will
CT
arrange for
pulmonary
CT pulmonary
angiolysis.
angio.
Okay. All right. Although you say the answer, but if you say it is pulmonary embolism after 3 days, you will be in trouble. And by the way, suppose we are 400 candidate enter the Cairo exam. I think 350, they say it is a case of pulmonary embolism. Okay? So take care, by the way. All right, so back again. So now what shall you do? What we will do? But you still have wrong answer also. You mentioned that you ask for chest X-ray for arterial blood gases, but usually you are treated the chest problem.
Or,
Who you need to consult?
I need for chest problem. The
Yes, for chest
chest,
physician or chest doctor.
chest
Okay,
physician.
so you can ask for internal medicine chest doctor, whatever the name, can come to follow up the patient. What is most probably they have? They have shortening of breath 3 days. What it could be? Think
Maybe
simple.
due to it may be due to hypovolemia because of bleeding.
Just a chest infection, hypovolemia don't cause shortened breath, but can
A
cause some
kidney.
dyspnea or
It may
weakening,
be
but
she may
it
be a
just
kidney.
maybe tachypnea, maybe chest infection. So what shall you
But
do later?
chest X-ray is
Yes.
not showing any chest infection. It's normal. So
Okay, so it is normal. All right. Because usually in the early, they have atelectasis or lung collapse before, or atelectasis or
okay.
mild chest infection, not necessarily appear in X-ray. So what shall you do now? What is your decision? Apart from the patient condition, what you will do for this her daughter? She need to take the patient away. So what you will do?
I will inform the patient and her daughter about the possible complications that may occur due to this premature discharge. Especially she
You
lives.
already spent the 20 minutes to tell that. You call me after you finish. Okay, so they already need to discharge, need to leave the hospital. So what shall you do?
Okay, I will ask her to I will ask the patient to sign a legal form of discharge against medical advice.
Okay, just
Uh,
a form of discharge against medical advice. Okay. Any advice you need to give to the patient?
I will advise her to take care of the drain. I will not remove it. And I will advise her if she felt any pain or if the drain or any shortness of breath to bring her to the nearest hospital.
So not your hospital to the how the patient knows the nearest hospital.
She can call the. I can leave her my number, and she can call me to consult me about the nearest hospital.
No, you can Google it. You can just give her the near. For example, this patient is go to another place, so you can just Google and know the nearby medical center or GP or nearby hospital. Okay. So it is a favor. You need to make a favor for this. So you discharge against medical advice, and you don't ask the patient to come back except because it is far away. It's about 100 kilo, and just tell her if any problem, she can go to nearby center. After that, they can manage by ambulance or send her by ambulance. So must be travel by ambulance, not by own car. All right. So it is easy station, but because you have an idea about the station, so it is easy to change the idea. Again, we don't have pulmonary embolism after 3 days, except in some rare situation. Although the student insists that it is pulmonary embolism, but it's not pulmonary embolism. Okay, Doctor.
طب يا دكتور شيء ممكن اسال حاجه؟ طب
اسأل.
الشورتنس اوف بريس وهي بعد يومين ثلاثه اقول اتليكسيس واقول حاجه تانية معاها مثلا زي اللي هي ممكن الهايبوفوليميا من البليدنج وكده ولا اقول اتليكسيس بس ولا اقول سيست
هو
انفكشن
احنا
ولا لو
هو
الاكس راي كلير
by
كده
the way
والاي بي جي
by the
كويس.
way this station is not for to discuss her medical condition. It is just to discharge against medical advice, but you put
اوكي
yourself in pulmonary embolism, which is wrong. So it is just, it can be chest infection, can be hypovolemia, but of course it is not your job. We just ask for investigation, and you just consult the chest physician or internal medicine doctor. It is not your job to do that. All right. It is not a case of differential diagnosis. It is a communication station. All right.
اوكي اوكي
This is very common station. And again, although we insisted that it is not pulmonary embolism, but in the last exam, I found a lot say it is pulmonary embolism, so it's no problem. Okay, anyone need to ask something about this scenario? Because it is
انا عايز
لو
common.
اسال
سمحت يا
سؤال
دكتور
تاني.
Okay, عايز what?
هسال حاجه تانية بس معلش اخر حاجه.
Okay, you can
لسه
ask.
عليك.
Okay.
البرفورمانس بتاعي كده مثلا انقص نص درجه مثلا كامله ولا
بص، هو لو احنا كميديكال نولج نديك فول مارك، لكن ككوميونيكيشن سكيلز او بروفيشناليزم هنديك 0 من 4. واخد
تمام
بالك؟ لان
تمام.
البروفيشناليزم means that you give a decisions, like for example, because if you say pulmonary embolism after 3 days, so it means that you are away from medical knowledge.
اوكي.
All right. This is station. You know, I just, by the way, if you found the station is repeated many time, it is have only one reason, that the student is not good performance. Okay.
Right.
This is why we
Right.
repeat it. Okay.
Right.
If you're okay. All right. Anyone need to ask?
دلوقتي يا بيه هو the patient was COPD. في أي station patient is COPD, should I يعني should I say إن I'm gonna offer oxygen on a Venturi mask, أو إن أنا مش هحطها on full scale oxygen?
This patient is already on oxygen and already in hospital. She is under treatment, and she under the supervision of the team, and they can manage. The scenario here is just to how to sign the consent for discharge against medical advice, and to know this is hematoma must be evacuated, and to know if the patient is alert and oriented, no need to take a decision from her daughter. Because, you know, in some country, like in Egypt, you can, for example, if my wife go to theater, I can sign the consent. This is true in Egypt, I think.
Yes, but it's the
Okay,
first witness.
but it is legally, even under the Egyptian law, it is illegal. It is not allowed. It's under even Egyptian law, under the medical advice or medical act in most of the world, we don't allow to sign a consent in behalf of the other, especially if I oriented. Okay? So this is scenario is just who signs the consent, discharge against the medical advice. You don't follow the wishes of the family. You need to concentrate with the patient.
Okay, right. And regarding the question that you asked, sir, about what did you do to the patient beside the full blood count and beside the blood and beside everything, what did I do locally to the hematoma itself? I packed, I evacuated.
No. Next day, if you see the script from the beginning, this prepare for tomorrow for evacuation and secure bleeding. Okay. Of course, what is written in the file is what is the answer of your question. So what you did for this patient is what is written in file. So it is just right in the file. He asked for full blood count, arterial blood gas, chest X-ray, and the finding. So this is your answer.
Okay.
So this is it is easy if you know that. All right. Any question again? So we can start the second scenario. Second scenario is common also.
زي حضرتك يا دكتور شيرين. خلاص انا
أهلا
كنت عايز
بيك.
اسال كنت عايز اسال على اي نوليدج موجوده او اي سؤال الاكزامينر بيسالهوني موجود في السكريبت، صح كده؟ بس حضرتك جاوبت يعني.
موجود في السكريبت. هو ما هو انت you must
الفايل
have what we
يعني.
called it what is called social intelligence. Social intelligence means that we ask you what is written in front of you.
تمام. اوكي.
So it is important to know that. But if you are volunteer, we don't respect that. So we don't say something is not written in the script.
تمام. اوكي.
Who need to be the second?
أنا ممكن أشارك لو
Okay, you can, no problem. So the second scenario is have two version. You call cardiothoracic consultant to refer a polytrauma patient to his unit. This is have two script. Either patient have you insert chest tube and they have 200 for 3 hours, or patient have widening mediastinum and the query rupture thoracic aorta. So we can start by this easy. So 35 years old man with RTA, road traffic accident, blood pressure 100/80 millimeter mercury, Glasgow scale 14/50, with left hemothorax, fracture left femur. You put a chest tube, drain 200 cc of fresh blood at time of insertion, followed by 200, second hour, the same third hour. You are Dr. Richard. So in paper, you write, I am Richard, SHO, working in emergency. You speak to Mr. Werfson, cardiothoracic consultant in charge today about polytrauma patient. So this is your job. This is a patient file. Mr. Man, worker, 35 years old, motorcycle, came to emergency by ambulance after accident 3 hours ago. On examination, Glasgow scale 14/15, swelling left side. The airway is patent. Patient can speak with us. So remember all this, we ask about this. Breathing is normal. No tracheal deviation, normal in percussion and auscultation. Chest X-ray left side hemothorax. Insertion of chest tube, drain 200 cc of fresh blood, followed by 200, followed by 200. Vital signs 100, pulse 120, blood pressure 100/80. Send the blood sample for group and safe. Send a sample for full blood count and arterial blood gases. Hemoglobin was 7, and you give 1 unit of blood. X-ray chest left fracture femur, shaft femur. Inform the orthopedic team, and they put Thomas splint. The abdomen is normal, confirmed by fast scan. And that's it. Okay?
Okay.
So in the first room, you just write your notes, you write what you need to write. After that, we come to the question. All right, so we can start. I share again the PowerPoint. Okay.
Shall I start?
Yes, can.
Hello, I am Dr. Richard, SHO, working in the emergency department. Shall I speak to Mr. Wolferson?
Yes, I am Mr. Werfson. I am the cardiothoracic in charge. Okay, so
No.
what you call me?
I'm calling you, sir, regarding Mr. Man, 35 years old male, came to the emergency department by ambulance after RTA 3 hours ago. On examination, his Glasgow coma scale is 14/15. His pulse rate 120 beats per minute, and blood pressure 100/80, and with a swollen left thigh. And his chest X-ray revealed right hemothorax. We bought a chest tube which drained 200 cc fresh blood time at the time of the insertion, followed by another 200 cc in the second hour, and the same for the third hour. I'm calling you, sir, to refer this patient.
Okay, so why you call me doctor? You did everything, so why you call me?
Because the patient
You make okay. Can you just tell me first from the beginning how to manage this patient from start?
from the start, we the patient, according to the ATLS protocol, ABCD. First of all,
what is airway? How to check the airway?
If the patient is speaking,
no, not if we speak about your patient. I write in the data. So is this patient airway is patent? He can speak to you.
The patient can speak with us.
Yes, airway is patent. Okay. What about
and
breathing?
His breathing is normal.
Okay, this patient can be potentially pneumothorax.
No, sir, because no
Why?
tracheal shift and the chest is normal in percussions and auscultation.
Okay, what else you did? You mentioned A, B, what else you did?
We took blood sample for group and ABG. First of
No,
all,
no, just one by one. You
okay,
said the blood sample and the hemoglobin, you found it is 7. So what you give him?
1 unit of fresh blood of blood, 1 unit
Okay.
of packed RBCs. Then we followed the amount of the blood in the drain, and we found another drainage
200,
of
200. Okay.
okay.
What about his lower limb? What in the lower limb? What
Uh,
happened in his lower
I
limb?
actually informed the orthopedic team, and they told us we should put Thomas splint as a primary.
They already put a Thomas splint because of
Okay.
fracture shaft femur. So why they don't make a fixation, blatant screw?
They wait until the patient is stable.
Stable from what? From which point?
From generally according to his.
Generally. Okay. All right. So, okay. So when you look into this fracture femur, you hear me?
Yes, sir.
Any important structure you need to look?
Like the pulse of his lower limb.
The distal pulse. So the
Distal
distal pulse is
pulsation
okay.
is intact.
Intact. Okay. What about the abdomen?
His abdomen is legs and
How to know
free
the abdomen is free?
by fast
What does
scan.
fast scan mean?
Focused assessment of sonography for trauma.
Focal assessment sonography for trauma. Okay. All right. So you don't tell me why you call me. We finish, but you don't tell me why you call me.
Because the patient has fracture. His chest X-ray showed that he has في حد في حد فأنا محسن.
I just
يبقى هو ما بين الجاجولار نوتش للسيمفيس بيوبس ميد لاين، او
مش
ان
أنا.
انا احدد التنس
حضرتك سامعني كده؟
انا سامعك بس في واحد داخل علينا بس
ميد
مش عارف.
كلافيكولار لاين. في حاجه ثالثه، هما الاثنين دول صح؟
انا مش عارف هو بيكلمني ولا بيكلم مين.
لا هو بيكلم حد تقريبا.
هو في محاضرة عليه غالبا، صحيح بس ميوت هيم.
ما انا بدور who means that I can mute him, but I think
محسن
I
أحمد يا
mute
بيه.
محسن Ahmed. Okay, all right. Okay, I can. All right, I think he's stopped. Mohsen, we have two Mohsen. All right, okay.
So intercostal space mid clavicular line.
We still have fetus. Okay. All
تمام يا
right.
باشا، هو كده خلاص.
I muted him.
All right. Okay.
I'm calling you, sir, because the patient chest X-ray showed that he has fracture rib, and I suspected he has hemothorax.
So what shall I do? You make everything. You make ABC. You make fast scan. You consult the vascular. You consult the orthopedic. So what shall I do?
I'm calling you, sir, regarding this patient because I think the patient may يعني مش عارف يدخل في شوك.
No, we have don't widen with the sun. Okay, so doctor, in this station, if your performance like this in exam, you don't take a mark. Okay, you know why?
لا يعني حضرتك قول لي.
First, you are in duty, and for example, you have aortic aneurysm. Okay, and you need to call the consultant. So what is the first thing after you introduce yourself? What you tell him? What is the approach if you have aortic aneurysm now? So what is your approach?
urgent referral and to put a stent for
No, we don't ask you about detail. We ask you about communication. So what you need to tell him. Okay, so we back again. Okay, so in this situation, if you start like this, it is not a correct way at all. It is very, very way or very bad presentation, because you have something dangerous. In this scenario, we can have either aortic aneurysm or dissecting aortic aneurysm or this indication. So I ask you in the other way, what is the indication of thoracotomy? After insertion of chest tube, what is the indication of thoracotomy? Indication of thoracotomy if insert chest tube and if it is
stoppage البليدنج ما وقفش صح كده؟
No, the indication
500 upon insertion.
Okay, or 200, 200, 200. Okay, so this is indication of thoracotomy. So when you start the conversation, so good morning, can I speak to Mr. Wolfson, the cardiothoracic? I have a patient of RTA, road traffic accident, and we insert chest tube, and they come 200 and 200 and 200. I think this is the indication, or my opinion, it is according to the guideline, is indication of thoracotomy. So I transfer the patient to you for thoracotomy. I contact the theater, if it is the same hospital or other hospital, I contact the theater nurse, I contact the anesthesia, I contact the houseman for cardiothoracic. So, and I also waiting you in the theater. Thank you so much. And after that, he start to ask you what you do for airway, breathing, circulation, what is fast scan, what is about the fracture femur, and they start like this. So your beginning is wrong. You understand?
I am an orthopedic surgeon فانا ما اعرفش بيتعاملوا ازاي مع الثراكوتومي مع
Okay, يعني it is the same problem. Suppose you have something urgent and you don't tell this history, and after that, so for example, if the patient have aortic aneurysm, you don't tell him patient and have something and have something and have something, and we found thoracic aortic aneurysm 7.5 centimeter is about to rupture. So you need to ask him, to tell him, we have urgent situation, you must come, this thoracotomy, this indication of thoracotomy, and after that he asks, you answer all questions correct, by the way, but the order of presentation or way of presentation is wrong. The same can happen if this widening mediastinum. We have the same scenario, widening mediastinum. So you need to tell him, I have widening mediastinum after trauma, and this is indication of thoracotomy. So we prepare the theater, anesthesia is ready, we're waiting you. After that, he asks you the normal question to take a knowledge mark. It is clear, by the way?
Totally clear.
Okay, so, all right. Anyone have comment on this or have this station before? Can have comment about this? Okay.
ممكن نطرح سؤال.
البرزنتيشن اوف ذيس كيس
الاكس راي صح؟
say again.
الاكس راي هيبقى موجود. الاكس راي التشست اكس راي هيبقى موجود في البيشنت فايل.
هيبقى موجود في البيشنت فايل.
بس انا قصدي يعني انا I will tell him that I've seen 1 2 3 in regards of this chest x-ray, this is why we need to do an urgent or emergent thoracotomy.
It is one of the indication of thoracotomy is if you have this. So this is the indication. Okay, you understand?
تمام.
Okay, the next is about.
بس في سؤال بس.
Yeah, you can ask.
بس نقطة اللبس هنا اللي هو الدكتور الكونسلتنت في نفس المستشفى وانا ريفير الكيس ليه، يعني انا ببلغه بالحالة بحيث يجي نفس المستشفى اللي انا فيها هيعمل العملية دي.
هو this consultant either in the same hospital in the cardiothoracic department, and usually this is what happened, or even in the other hospital, but in the both situation you need to call the hospital. Suppose you have in the same hospital, of course, maybe the same theater, but you need to tell the theater, you need to tell the anesthesia, we have thoracotomy.
Yes.
It is
but
what is
if-
done in many hospital. You need to prepare everything before he coming.
I am fear from this situation. This patient has active bleeding, and I fear from other large trauma to aorta, and the patient die in the route to the other hospital.
No, we don't mention other hospital. Whatever, usually can be the same hospital or can be transferred, no problem. But what shall we do? It is indication of thoracotomy. Don't go to in the side way. This is indication of thoracotomy, so you must come to do thoracotomy.
Yes, okay.
All right. Okay.
All right.
طب معلش دكتور شيرين، معلش سؤال اخير. يعني هو في حاجه في الفايل بتاع العيان بيعمل، يعني بيقول لي مثلا العيان ده يعني بتبقى فرانكلي واضحه، ولا لازم انا بيك اللاين اللي انا اعرف منه؟
to be clear, if the doctor, I think Dr. Muhammad Zahra, who he says an orthopedic, Mahmoud Zahra, if he's in his presentation and examine this way, he 100% he fail. Okay. We don't, the item here is what is the indication of thoracotomy. The indication of thoracotomy according to the ATLS is if you insert chest tube and have 1.5 liter, if you insert chest tube and have 150 to 200 for 3 successive hours. So don't wait 4 hours, 5 hours, the patient will die. So it's not written because this is the guidelines, it's not written. It's not written in the file, it is indication of thoracotomy. This is the only knowledge we need to tell us.
تمام.
Okay, clear?
تمام. شكرا.
All right. This is a difficult station, by the way, and many students failed on it because they don't understand what is the situation. So you need to explain to him this is a dangerous situation, they must come. Okay, who's next?
ممكن انا اخد الستيشن.
Okay, anyone what's your name? All right, okay. Hisham, we have a lot of cases, don't worry. You are also Dr. Richard, SHO for Mr. Wolfson. You call Mr. Browse, consultant in charge today, to tell him about case is not under his supervision. What is this case? Mr. John Carter, 65 years old, in the HDU, high dependency unit. The high dependency unit nurse, the patient have Oliguria after right hemicolectomy. Call you as the patient have Oliguria after right hemicolectomy. I think this is the station whose Dr. Hilal said they have to him. It's very common station. So this is a personal history. Mr. John Carter, 65 years old, patient, unexplained anemia, iron deficiency anemia, loss of weight 5 kilo in the last months, no alter bowel habit, no bleeding upper rectum, no tenesmus or fecal incontinence, abdominal ultrasound normal, colonoscope show mass in ascending colon. It is adenocarcinoma. Tumor marker CAA is elevated. CT, thorax, abdomen, pelvis are normal. Operative detail, surgeon Mr. Browse, anesthesia Rubin, right hemicolectomy, no colostomy. Ileostomy, he has bleeding during surgery and take 2 units of blood and 1,100 milligram of normal saline. Hemoglobin was 12, dropped to 10. Tube drain is inserted in the right paracolic gutter. Post-operative follow-up, blood pressure 100/80, pulse 120, temperature 37, abdomen is lax, the blood from drain, full blood count as you show here, the hemoglobin is become 9 now. Other is within normal. This is liver function test. Renal profile, just urea is little high. Creatinine is slight high. Arterial blood gases, as you see here. And this is a medical chart or drug chart, this is gentamicin. And this is the fluid chart, in and output chart. The patient take 1,100 and output is 400 only. This chest X-ray. I think that's it. Okay. Anything you need to see it again? So here you can find many chart. You have drug chart, maybe other drug. You can find input and output chart. You found chest X-ray. You found full blood count. You found arterial blood gases. So a lot of things and operative detail. So all this is written.
Okay, sir.
Okay.
Okay.
All right. Okay.
Okay. Hello, my name is Dr. Richard. I'm a senior house officer who's working for Mr. Browse. May I confirm
Yes.
that I'm speaking with Mr. Wilson, the consultant in charge?
Yes, I am Mr. Wilson.
Okay. Hello, sir. I'm speaking to you regarding a patient. Is a 65 years old patient who has underwent right hemicolectomy. He's now post-operative day 1. His urine output in the last 8 hours is about 10 to 20 milliliter. The output is 400 milliliter in the past 24 hours.
Okay, so what is normal
Clinically,
urine output, doctor?
0.5 to 1 milliliter per kg per hour.
Milliliter per kilogram body weight per hour. Okay, so what is definition of oliguria? You mentioned it is oliguric. What is this?
The output was less than 500 milliliters per day.
Per day. Okay. All right. Okay. What else? What is
Then
usually the causes of oliguria?
Pre-renal and renal and post-renal. Pre-renal due to hypovolemia, renal due to nephrotoxic drugs.
Okay.
Or,
so no, just relax. In this patient, if you look, you say renal due to what? Toxic drug. Can you can you check the medical chart? What is medication he took?
Yes, sir. I've already checked, and he has taken gentamicin antibiotic, which is known to be nephrotoxic.
Okay, so you need to stop it.
Yes, sir. We already did.
Okay, all right. So in the aminoglycoside or some medication, or sometimes the first time to have EC inhibitor can cause renal impairment, so we need to stop it. Okay, so this pre-renal, what is post-renal?
Obstructive uropathy, the presence of stones, or the blocked catheter, or benign prostatic hyperplasia.
Okay, that's enough. All right. Okay, so what is lab investigation you did for this patient?
We've done a full blood count, an ABG. We've done a renal function test, a liver function test.
Any abnormality?
Yes, the hemoglobin was pre-operative 12 milligram per deciliter. During the operation, it went down to 10. He received blood intraoperative, and now the hemoglobin is 9. The urea.
So you mean that the patient, he lost the blood during operative notes. So you check the operative notes, you found that.
Yes, sir.
Okay. All right. Okay.
Regarding the urea and the creatinine, they are slightly elevated. The potassium is normal, and lactate is normal.
Potassium is important.
Yes, sir. Potassium is very important because in renal failure patients, they can have hyperkalemia, which can be.
So you think this patient is bleeding now or not?
No, sir. The abdomen is lax and the drain is nil.
Okay, because the abdomen is lax and also they have a drain, and the blood pressure is not decreasing. Okay, so the nurses call you, and this patient is oliguric. Okay, so what is the explanation of that?
The explanation of the oliguria due to the nephrotoxic drugs and
no, doctor, relax. He actually this is the first day, so he will stop it now. So it take a time to be nephrotoxic, so forget that.
Okay, he took 1,100 only cc per the 24 hours. The past 24 hours as an intake in the fluid chart.
All right. So you mean that this patient is pre-renal cause due to dehydration, due to insufficient taking, and you check that by looking to the input and output chart.
Yes, sir.
Okay, that is true. All right. So okay, so it is just oliguria due to that. Are you sure?
Yes, sir.
Okay, so when you look into operative detail, apart from this operation, other operations in surgery and the gynae, and the patient have oliguria, why we looking for operative detail?
To look for if it's an pelvic tumor, like total abdominal hysterectomy, we usually, there are common incidents of injuring the ureter or taking
injury of the ureter. How to prevent that? If you are junior in the gynae department,
we insert
you are junior.
Yeah, we insert a stent, a double J or a double J
okay. So you
catheter.
start ureteric stent, so can
Yes,
be
sir.
ureteric stent. So it is important to looking for the type of operation, because in hysterectomies and in abdominoperineal and colonic surgery, you can injure it, you can ligate by mistake the ureter. So in some center, especially have a lot of junior, they put metallic stent or ureteric stent or G stent in the ureter to be easy identify. Or they can identify as the bifurcation of the common iliac to right internal and external iliac. Okay. So what you will do for this patient? How to treat it?
I will keep monitoring the vital signs. I will increase the amount of fluid intake. Rather than 1,100 cc, I will increase it to 3 liters per day.
Okay. If we don't make this point and you need to do something like test, of course, this patient in HDU and they have central line most probably, or easy to insert central line. How to know the cause of this dehydration or the cause of the oliguria? How to know that?
I will do a fluid challenge test.
What is this?
I will inject in the CVP 150 cc of saline, and then I will monitor the water column that indicates the CVP. If it remains,
no, doctor, it is not water. It is not water. We called it water wrongly. Okay. So what is used in central line? What solution used in central line? You see central line before or not? Anyone?
Yes. It's a ball in a column that we attach to the central line, and then we see the
no. In the central line, what is the fluid?
saline.
Saline, not water. We called it water wrongly. The central line is 5 centimeters saline, not water. But because saline and water is the same, but it does not mean that we put water. You agree with me or not?
Yes, sir. Of course, yes.
You use water or saline?
No, saline. Normal saline from the...
Okay, so you're looking for the saline. So we have 3 options. What is the 3 option if you have fluid challenge test?
Okay, I injected the fluid challenge test, and then I will see the response of the patient. If the CVP or the central venous pressure remains high, then he's hypervolemic, or he has more fluids in his body.
Yes.
If the central venous pressure rose and then fall again to the normal, which is from 8 to 12, then the patient is normovolemic. If I injected the fluid challenge test, and then the CVP, the central venous pressure was low and it rose just a little bit and then fall back again, then this means that the patient is in hypovolemia or dehydrated.
Okay.
So I need to
so you see the curve now. You see this curve.
Sir.
Okay. In other station, not in full call, you need to draw that. All right. So if the patient have, like for example, it is still high central line, and it is in ICU, what is the other cause of the high CVP?
Either he's full of, he's hypervolemic.
Apart from hypervolemic, what else?
Cardiogenic causes.
No, just speaking the common thing. If this patient in any machine can cause false high CVP?
Yes, if he's mechanically ventilated.
Okay, so it is important if the patient in mechanical ventilation, especially PEEP system, so usually they give the false high central line. What is normal central line again?
From 8 to 12.
What is the unit?
Millimeter mercury. And there is
doctor, relax. in your hospital.
Yes.
By the way, in exam, if you don't see anything, just I don't see it. In your hospital, you measure by millimeter mercury.
No, millimeter H2O.
Saline.
Yes, saline.
Not H2O, saline. Mercury, you have some adapter. You need to connect it to other machine and other. So it is correct, but it's not practical. It is important in exam is a practical exam. Practical exam means that if you do something, you must either do it or hear it or done in your hospital. So don't something historical or something written in book. Central venous pressure is measured by saline. It is 5 to 10 centimeter saline, not water. But in books we called it water because it is the unit. But in practical we don't use water. If we use water, the patient will die for hemolysis. We don't use water. Okay.
Okay.
All right. Well done. So this station is very common, and it is just oliguria because the patient don't take enough fluid. But the idea of this station, you need to look in for operative detail, to looking for bleeding or injury of the ureter. You're looking for the medication, maybe have nephrogenic drugs. You're looking for input and output or fluid test or fluid chart. You need to look in if this patient have a catheter or no catheter, and if have a catheter, it is blocked or not. And you need to know that the patient have pre-renal, renal, post-renal causes of oliguria, and you know the definition of oliguria. So this is very common and easy station, and very, very common. Any question about this station, by the way?
At the end of any station in the phone call, sir, so the consultant will give me, and the consultant will give me his recommendations, right?
What you mean by his recommendation?
Yeah, I'm calling the consultant to get the recommendation.
You give him the recommendation. You not him. Like for example, so now, doctor, I will this patient because of oliguria, I stop the gentamicin, I give him fluid guided by central venous line, and I do fluid channel test. Thank you.
Okay, thank you, sir.
So he don't tell you, you tell him.
Okay, sir.
All right. Who's the next? We have 3. So we have I just okay, all right, okay. I just see which the station is. All right, okay. So I just share the screen. Okay, who will start? What's your name?
أنا غنيم لو
غنيم.
حد
يلا.
يعني
Okay, no problem. You can. We have a lot. So we have you are Richard with Mr. Wilson again. You call Mr. Brown, consultant chart today, to tell him about case not under his supervision. Miss Anne Mary operated yesterday for laparoscopic cholecystectomy, has bile coming from drain. So this patient have laparoscopic cholecystectomy and have bile come from the drain. 45 years old woman complain of abdominal pain, mainly in her right upper quadrant after fatty meal, been radiated to the right shoulder, pain score 7/10, nausea, no vomiting, no change in urine or stool color, no itching, so it is not obstructive jaundice. She is overweight, body mass index 33, non-smoker, not drink alcohol. She is housewife, married with 3 children, abdominal ultrasound, multiple small gallbladder stone, chest x-ray, normal. Operation by Mr. Wilson, anesthesia is Rubin again, and the laparoscopic cholecystectomy. There is a lot of adhesion till reach the calot triangle. The use of harmonic scalpel. Harmonic scalpel is ultrasound machine for dissection of adhesion. Tube drain is inserted in the right hepatorenal pouch. Post-operative first day follow-up. Vital sign 130/80, pulse 110, temperature 38. On examination, tinge of jaundice, abdomen is lax, bile come from a drain with no change in the urine color. Urgent abdominal ultrasound show minimal intra-abdominal collection, but no intrahepatic biliary dilatation. Full blood count, white blood cell 11, hemoglobin 13, other data with a normal. Liver function test, renal function, urea is okay, creatinine, okay, arterial blood gases, okay, and that's the medication chart, nothing, just antibiotic. Input and output is okay. Chest x-ray is okay. All right, so this patient, first day post-operative, have bile come from the wound, or bile leakage after laparoscopic cholecystectomy. Okay, you can start.
ممكن الفايل بس عشان الاسم مستر
Okay, all right. Okay, so you are Richard. I just mix the data. You are Richard, and you speak to Mr. Wolfson. Okay, all right. So you can start. You are Richard. You are houseman, SHO, and for Mr. Wolfson, and you call Mr. Brown, the consultant in charge.
Okay. Hello.
Okay. Hello. Yes.
I am Dr. Richard, the SHO. working for Mr. Wilferson.
Yes.
I'm calling to speak to Mr. Browse.
Yes, I am Mr.
diabetic.
Browse.
Okay, to refer a patient.
Okay, you don't refer, just to take my opinion. You take his opinion for a case.
To take
Okay,
your
all right.
opinion.
Okay, all right. Is my
My
patient or is my patient or
No,
not? Okay, all
no,
right.
no.
Okay. So what does this patient have?
Mrs. Smith is she's 60 years old. She's underwent an interval laparoscopic cholecystectomy. She's 45 years old. Underwent laparoscopic cholecystectomy yesterday with Mr. Wilferson, and she is complaining of abdominal pain, and we noticed bile coming from the drain. No
Okay,
changes were
so what
noted.
is the possibility of this bile leakage after laparoscopic cholecystectomy? Give me the option. What is the possibility?
Maybe common bile duct injury, or maybe cystic duct stump leakage due to slept eclipse.
Cystic what? Cystic?
The stump of the cystic duct leakage.
You mean celeb the cystic duct clips or okay or ligature? Okay, so you either injury of the common bile duct or celeb the cystic duct clips or suture. What else?
Maybe leakage from the liver bed of the gallbladder.
From the liver bed or accessory cystic duct. So you have four
or
options.
accessory cystic duct.
Either cystic duct clips or suture slipped, injury of common bile duct, accessory cystic duct, leakage from the liver bed. Okay, can be obstructive jaundice.
No.
Why?
Because the patient is the urine color is normal, and the abdomen by examination.
Urine color is normal,
Urine
and
color
of
is
course,
normal.
if you have bilirubin, bilirubin will be normal. Okay, so just the possibility, if this patient have jaundice now, not this patient in general, what it could be? If the
Could be an
patient
obstructive jaundice.
no, just one by one. Suppose this patient first day post-operative become jaundiced, what it could be? What is the possibility?
Could be a retained common bile duct stone.
So can be either celeb stone in the common bile duct or iatrogenic ligation of the common bile duct. Okay. If suppose this patient after laparoscopic cholecystectomy develop jaundice after 1 month, what is the possibility?
Maybe cholangitis, ascending cholangitis.
No, cholangitis is not occur after 1 month. We just speak about surgical causes. So you mentioned if the patient have obstructive jaundice second day after surgery, can be due to slipped stone or iatrogenic ligation of the common bile duct by mistake. But if they developed after 1 month, so most probably they have injury of the common bile duct and healed by stricture, so can be stricture of the common bile duct. Okay? All right. After that, is Mr. Wolfson used to put a drain in laparoscopic cholecystectomy or not? Usually.
No, but in this case there were a lot of adhesions.
Okay, so because of the lot of adhesions. So, all right. So this patient can have now biliary proteinitis?
No.
Why?
No signs of by examination. There were no signs.
No.
of
Suppose they have a bile leakage, but they don't have biliary proteinitis. So be logic. This patient have bile leakage. Yes.
Okay. There is a drain.
There is a drain. Okay. So this patient is not developed biliary proteinitis because they have a drain, so the bile come out. So suppose this patient have no drain. So how to drain this bile? Suppose we forget to put a drain. How to drain? You make ultrasound. You found the patient have mild collection, about 500 cc of bile collected in the right hepatorenal pouch. What you will do?
Ultrasound guided aspiration.
Not aspiration, put a tube. It is ultrasound guided percutaneous drainage guided by ultrasound.
Drainage.
So this is the second option. Okay, so how to treat this patient? We speak about the patient, the original patient. which is have bile leakage first day after laparoscopic cholecystectomy. How to treat it?
I already started fluid resuscitation and antibiotics after consulting the
What
microbiologist.
antibiotic usually? Name. Which antibiotic usually give it in biliary system?
Biliary system. I don't know.
In abdomen, what antibiotic common use?
Cephalosporin.
Cephalosporin and metronidazole to avoid cholangitis.
Cholesterol and metronidazole.
Or augmentin, whatever you need a combination for anaerobic and anaerobic. So you give antibiotic intravenous fluid. So what else? How to know what is the cause of this leakage? What
I
we
need to
will
perform
do?
an ERCP.
You perform ERCP
Delineate.
or MRCP. So ERCP is better. So suppose you make ERCP, no stone, and just found little injury in the common bile duct, what you will do?
A stent.
Just
this.
put a stent. You can put it sometimes for 3 months. After that, you remove the stent. So the treatment here is intravenous fluid, antibiotic, ERCP, and after that, if a stone, you remove the stone or put a stent. That's it. After that, you summarize. Can you summarize just to see how to summarize?
Okay. This female patient, 45 years old, post lab poly 1 day ago, presenting with generalized abdominal pain, and the bile was noticed in her drain. We started fluid resuscitation and antibiotics, ordered and antibiotics, and we need to perform an ERCP to delineate the cause of leakage and source of leakage, the presence of any stone, and probably placing a stent if there is leakage.
All right. Thank you. Okay. All right. So
Maradi,
again, no, it is good. Okay. Excellent. All right. So it is just a further experience. You know that your performance in the real exam in the first station usually bad. At the end of the stations, you are good. So this is
لا بس
why
والله
it is
بنستفيد من
17
حضرتك يا
station.
دكتور شيرين والله.
الله يكرمك يا سيدي.
عشان
Who's
احنا
next?
عشان الوقت متعودين على اللي هو نحفظ وخلاص، ما بنركزش مع فحضرتك فرقتنا من الحته دي يعني.
ربنا يسهل إن شاء الله. Okay. So who's next? We have
take it.
Seroma patient. Okay. What's your name?
Ahmed Fouda.
Dr. Ahmed, you are welcome. So,
Allah
Dr.
يخليك.
Ahmed, we will have, I think I share the screen now. I see share. Okay. All right. So, this is, you are Richard again, and you work with Mr. Browse, consultant in charge today, to tell him about trauma case. So again, all data is written in the script. So 35 years old man came to emergency department after RTA 30 minutes ago. Airways patent, patient can speak to us. Breathing is normal, no tracheal deviation, normal percussion, normal auscultation, glaucoma scale 13 at time of arrival. Right eye slight dilated. Vital signs, blood pressure 130/80, pulse 100 per minute, have left open fracture tibia, no pulse in his left dorsalis pedis. It is open fracture and dorsalis pedis. So send sample, group and safe, send sample blood sugar, arterial blood gases, hemoglobin 7 gram, so you give 1 unit of blood, X-ray, left fracture, shaft femur, inform orthopedic team and vascular consultant, abdominal normal confirmed by fast scan. On the skull examination, they have battle sign. Battle sign is ecchymosis around ear, right side hematoma. Fast scan is normal, chest X-ray normal, cervical lateral view is normal, abdominopelvic X-ray is normal, CT brain done, waiting for the report. If right, waiting for the report, we show you at the end. A secondary survey, AMPL, no allergy, no history of diabetes, hypertension, last meal 4 hours ago, event is a patient driving a car, wearing a seat belt and hit a tree, orthopedic report, fracture shaft femur, type 1, class wound wound that less than 1 centimeter long, it is something called the Gastello-Anderson classification. Distal pulsation is not felt. The urgent surgical interference with the vascular consultant. Vascular opinion, dorsalis medius not palpable by handhold Doppler. This is a full blood count, normal. Bilirubin, liver function, renal is normal, arterial blood gases within normal, and medication sheet, nothing, and fluid chart and chest X-ray. This is a back of ear, what we called it battle sign, and this is a X-ray skull, CT skull, not X-ray, CT skull. Okay, nothing else. Okay, so I just in the power presentation, these 5, I just show it again. All right. So this is head injury and they call trauma team. Okay, I share again. So all data is repeated again. You can see the data again. Okay, you can start.
Okay, hello.
Hello, yes.
This is Dr. Richard, the senior SHO. Can I confirm that I'm calling
Yes,
Mr.
I am Mr. Browse, the consultant of church today.
Thank you. Thank you, Mr. Browse. I would like to present the polytrauma patient to you if you don't mind.
Okay, you can.
So we have a 30 years old male patient who had presented to our emergency room about 30 minutes. And by primary survey, the patient has a patent airway, normal breathing.
Okay, so all right. Just I ask you some question. You mentioned is have a battle sign. What is battle sign and the raccoon eye indicate?
This is most likely indicating fracture base of the skull.
Fracture base of skull. Okay, thank you. All right. Can you comment on this patient pupil? Is written in the notes. Can you comment in the pupil?
It is slightly dilated at the right pupil.
In the right pupil is slightly dilated. What it means?
This is mean that there is loss of the opposed parasympathetic activity.
No, we don't be so clever. If the patient have dilated in one side, it is means that the trauma, the extradural in right side or left side?
On the left side.
No.
On the same side. On the same side.
Okay, the pupil dilated in the same side and paralysis in the other side. So this is important. So this is means that's the patient. But if you remember, if you see the X-ray skull, the CT, it is right side.
Yes.
Okay. All right. Just be logic.
Yes.
Okay. All right. So you mentioned what is the glaucoma scale of this patient?
13/50.
What is the indication? When we put endotracheal tube, at which level of glaucoma scale?
Below 8.
Below 8. Okay. What is glaucoma scale item?
It discussing the eye response, the verbal response.
So eye response out of how many number in eye response? It is 4. Verbal
4,
is 5.
5, and the motor of 6.
Of 6. Okay. All right. So you mentioned also in the presentation we take ample history. What does this ample history mean?
Ample history.
Ample history. Okay. At this time you just open the file, you can find it. Ample is abbreviation of, you see the screen now.
Allergy, medication, past
allergy, medication, past history, and the last meal and the event. So when this patient take his last meal, it's written in notes also 4 hours ago. So why it is important to ask about last meal?
For anesthesia preparation.
No, not for anesthesia. It is just to avoid aspiration. So if the patient just eat, so what you will do? If this patient say he come from the restaurant and have an accident, so what shall we do?
To secure the patient's airway.
How to secure it?
with the prophylactic endotracheal
No, how to
intubation.
avoid aspiration? No, we don't. It is not indicated for endotracheal, but to avoid aspiration, what we put?
We put the patient on the lateral side.
Okay,
head
what
lateral
is
side.
what is the tube we put? Nasogastric tube.
Nasogastric tube. To decompress, you mean? To decompress the stomach.
If the patient is just is eating, suppose the patient say, I go to rostrum, I eat, I come out, I have car accident, so you need to insert nasogastric tube to avoid aspirated pneumonia or aspiration.
Okay.
And you mentioned is the abdomen is lax.
Yes.
So how to know that?
With the primary survey, it is examined by fast scan.
What does fast scan mean?
It is a focus assessment sonography of a trauma. It assesses the pouches inside the abdomen, including the.
It's done in how many area?
In 3, 4.
At least 4 areas.
At least 4 areas. Yes.
So the right side for liver, left side for spleen, epigastric
pelvis.
area for cardiac tamponade, and the lower for any free fluids. Okay. Yes. So if you see the CT of the skull, what is your impression?
There is a hyperdense right-sided biconvex lesion. It's most likely a right epidural or extradural hemorrhage.
Yes, with little subcutaneous hematoma. What is the cause of extradural hemorrhage?
Due to injury of the middle meningeal artery.
What is the origin of middle meningeal artery? From what? Which artery?
It's coming from the maxillary part. Maxillary
artery. And go to the skull through which foramina?
Through
foramen spinosum.
Foramen spinosum, yes.
Okay, all right.
Yes.
Okay, so this is extradurals. Apart from this, we mentioned that this patient have fracture.
Open fracture femur.
Open. What mean by open fracture femur? How to fix the open fracture? General principle. External fixator.
External fixation, yes.
So by external fixator. So you're looking for pulsation. How to test the pulsation?
Testing pulsation can be clinically or by bedside Doppler.
Handhold Doppler. Okay, so we have handhold Doppler and we don't find dorsalis pedis. So this is situation. You need me to come urgent to the hospital to see this patient, or can waiting till tomorrow?
No, he cannot wait until tomorrow because.
What is the maximum hour we can leave the limb ischemic?
6 hours at max.
6 hours. So you need me to come now to the operation.
Exactly.
To the theater. Okay.
Yes.
So you call the anesthesia. You prepare everything.
Yes, of course, sir.
Okay. So what else you need to contact him?
What else I need to tell the doctor?
Anesthesia, nurse, and vascular team, and
orthopedic, of course.
And orthopedic. Okay.
Yes.
All right. So in this situation, this is open fracture. So you can do the pose, you can do the brain also. But what we need to confirm that is important to know. If you have open fracture, so the fixation is by external fixator. External fixator can be variable, can be Elizarov, can be something, whatever, no problem, but just must be external fixator. If the patient have loss of the vascularity distal pulsation, so you must have vascular team. So this patient is urgent. Even extradural is urgent also, but because we just making for discussion to ask you a lot of questions. So it is important again, if you start by, suppose I am the vascular surgeon, not the trauma team, so you need to ask him, so doctor, we need you urgent because we need to save the limb because the patient have no distal pulse. Okay.
Dr. Shane, I think with open fractures that they are not still stabilized, or at least they do the external fixator and they reassess again the pulsations. Sometimes it's not.
No. What you say is not an open fracture. This is in the both fracture. You make you make reduction under anesthesia and looking for pulsation.
Yes.
Okay, but this is a fracture shaft femur, so most probably either have hematoma or injury.
Injury. Yes.
Of course, you consult the vascular whatever, but he must have. Usually in the theater, we have a screen to see the bone, and also the same screen use it to inject the dye to see the angio.
Yes.
So they have both. All right. Any question in this topic again?
Thank you.
Anyone need to ask anything?
I don't think so.
All right.
Everything-
So we have two scenarios again. The last scenario, not the last, number 6, is to speak to registrar any charge for
انا ممكن اشارك لو
you can come no problem. We just see the script, so it is 6. Okay, I share the screen. Okay, share again. So you are Richard again. For Werson, you call Charles is IT. IT is intensive care unit, intensive trauma care. Trauma, we have 3 units. So we have ICU, we have HDU, we have ITU. Intensive care unit is intensive care unit. 1 nurse to 1 patient. HDU, 1 nurse to 3 to 4 patient. ITU is intensive trauma unit as deal with the trauma patient. Okay, so you see the screen now. Personal history, can I read it? So, 37 years old woman had a sudden abdominal pain, confused, and examination suspect perforated viscous. Urgent laparotomy will be required. She is chronic obstructive pulmonary disease, acute renal failure on dialysis, blood investigation. Done, arterial blood gases done, ECG, chest X-ray done, blood pressure 130/80, pulse 120, send the blood sample for group and safe, send the sample for full blood count, blood sugar, arterial blood gases, abdomen is rigid, tender, mainly in epigastric region, chest X-ray done, no allergy, no history of diabetes or hypertension. Usually the X-ray you see it down, full blood count, white blood cells 11, hemoglobin 12, liver function, renal function, arterial blood gases here is not good, is some abnormality. Okay, lactate is 4, and now lactate is very important topic. Okay. This is the arterial blood gases, pH 7.2, BO2 12. This is in kilopascal. This is the normal value in kilopascal. Bicarbonate is low 15 millimole. X-ray, medical, okay, input, output, and this is the chest X-ray. But before we start, what you see in the chest X-ray?
دكتور شيرين انا السكرين عندي مش باينه خالص.
مش باينه خالص. Okay, I will try again. Stop sharing again.
انا ممكن اقفل وادخل تاني.
No, شايف دلوقتي ولا
لا مفيش حاجه.
اوكي، طب اقفل وخش تاني، مفيش مشاكل.
تمام، معلش.
No problem. اوكي،
طب سؤال يا لغايه لما يرجع تاني، كنت الانديكيشنز بتاعت الارجنت سي تي ان انا اعمل سي تي وذن الاورز اوف برزنتيشن اللي هو initially
you mean CT؟ لا CT برين.
يس
هبعتها لكم عشان دي في الجايد لاين. CT برين والادميشن نيورو سيرجري indication.
اوكي سور.
Okay, you are back. Okay, I share again. I think you are back or not yet? انتوا طبعا شايفين الاكس راي. You see the X-ray doctor or not? What his name?
شايفينها يا بيه.
So what is your see he is an X-ray?
Pneumoperitoneum.
Here under the tram. Here under the tram
Okay.
on the right side.
Okay, so what is your diagnosis?
Perforated viscous mainly.
Yes. Okay, so Dr. Zahra, you see the chest X-ray now. Dr. Zahra is not here. You are
معلش
back or not?
معلش يا دكتور
Okay.
شيرين، سؤال بس. هو انا مش
اس-
عارف السؤال يعني
لا، اسأل.
منطقي ولا لا. هو في ناس بتقول اير اندر diaphragm وفي ناس بتقول جاز اندر diaphragm. وات از ذا ديفرنس يعني؟
ما فيش difference خالص. اي
يعني
حاجه accepted. خلاص، هو برفوريتد فيسكس وخلاص. عايز تقول اير، عايز تقول جاز، ذا سيم يعني. ما فيهاش مشاكل. خلي الموضوع بسيط كده. Don't be so complicated. Okay, I think Dr. Muhammad Zahra is back or not? Dr. Zahra, are you back or not? All right. Okay, I think anyone can start. You see the scenario.
ماشي يا بيه لغايه لما يجي
Okay.
يعني.
لغاية ما يجي ممكن ياخد اللي بعديها. No problem. So I just open the PowerPoint presentation. Okay. So this is the indication of the admission patient to the ICU. This is the main issue. So you can start. If you need, you can start and can tell
I
me.
haven't seen the presentation.
Okay. All right. So this is what is in this script is 73 years old woman had sudden. Okay, I think he's back. Okay. Dr. Zahra, you are back. Okay, Muhammad Zahra. This is the PowerPoint presentation, Dr. Zahra. You can see again, just remember, a 73 years old woman have a sudden abdominal pain, confused, urgent laparotomy is required, and you speak to the IT or the man who is responsible for the trauma unit to book or to have a place, and he don't have a place. Okay. So this is the communication skills, the proper communication skills. So after you confirm your name and to confirm his name and you speak about the patient. So he will ask you, what is the indication to admit this patient? For example, he will ask you, what is the criteria? This patient have simple condition. He just perforated viscous. You just make 2-stage. It don't take a time. So perforated viscous is a minor case to be done by laparoscopy. So why you need to admit her in ITU? So this is a question. This is simple operation. You just have a perforation. You make 3-stage, put omentum patch. So why you need to admit her to ICU? This is a question.
Can I see the script again? I think because the patient is COPD, 73 year old, and the patient is COPD and has background of acute renal failure on dialysis.
Okay, so you need to admit this patient because of the comorbidity in the form of the respiratory problem and kidney problem. So this is the indication. Okay. So now can tell me in general in ICU, not ITU, in ICU, what is the indication to admit the patient in ICU?
In general?
In general.
أنا شايف السكرين
ما خلاص مش مشكلة. قول.
تمام. لو patient needs regular monitoring and the patient patient has uncontrolled hypertension, diabetes, heart problems.
Okay, so is mainly the general is the patient need ventilatory support or support. So you can say, for example, if the patient need close monitoring or have comorbidity like uncontrolled hypertension, uncontrolled diabetes, patient need cardiopulmonary support like ventilator, or patient have any organ failure. So this is the main indication to admit in ICU. You agree? Okay. So you can see her blood gases. What you comment on the arterial blood gases?
pH is low, so acidosis, PO2 normal, PCO2 normal, bicarb low, metabolic acidosis.
Metabolic acidosis. If you look into chest X-ray, what you see?
Air under diaphragm.
Okay, most probably perforated viscous. Okay, if you see ECG, what you see in ECG?
Not
I
clear.
make it bigger. Okay. If looking to this area, if you look in here, what you looking for? Or here, for example, what is B look like?
Absent.
It is like atrial fibrillation, so maybe have atrial fibrillation.
بس
Okay, all right.
دكتور شيرين، هي الصورة بتبقى أوضح من كده طبعا في الامتحان، صح؟
طبعا هو عادة لما بيوريك if you have ECG usually it is AF. I have another one maybe. All right. So I just mentioned the difference between HDU is 1 nurse to 3 patient, ICU is 1 to 1. In some Glasgow, they called it a step-down unit. All right. So now we know that the indication to admit in ICU if the patient have organ failure or need support. So your patient, she have renal failure, she have chronic obstructive pulmonary disease. So although it is a minor surgery, we need to put in the ITU. But actually, I don't have a bed. And you have 6 patients, 6 surgical patients in your unit. So what is your opinion how to manage this?
I think I will continue managing this patient in the longer in the recovery room and
no, recovery room is the theater. Recovery room, it is in the theater. They close it at 6 o'clock. And the emergency room will act. So you can see the screen.
I don't have any. Okay, I see. Have. Okay, I will discharge the more stable patients.
Okay. So you got the idea. So you have many patients in the unit. So what you will do, I will come to see if I found any patient is stable, so I can transfer him to HDU or to the ward. So we have a place for our patient.
Okay.
Okay, you understand the idea? We don't, in the ICU, we don't call the bed manager. Bed manager is for the main bed in the hospital. But because the decision to transfer the patient from ICU to other area is the doctor decision. Because this is ITU, so it is trauma, so it is belonging to the surgeon. But if it is ICU, ICU is run by the ICU team, so it's different team. Or medical team, which is different team. Okay, you got the idea?
Okay.
Okay, last scenario, we have the last scenario. Of course, at the end, you summarized that to the consultant and it is easy.
Can I summarize?
You can summarize. Can.
بس أنا مش فاكر اسم البيشنت.
Okay, no problem. This is okay.
I am calling you regarding Miss Annie.
Anne Mary, yeah.
Anne Mary, 70 years old, female, with a background of COPD and
heart renal failure.
Acute renal failure on dialysis. We're now complaining with acute abdominal pain, and I'm calling to reserve a post-operative bed after مش عارف تعمل
after surgery, after operated laparoscopic closure of the perforated viscous. So after that, I transfer her to your unit because we have no bed. So I come to see is any of my patient or my surgical patient is little stable, so I can transfer him to HDU or the ward, and you have empty bed for her.
Okay.
Okay. All right. So it is easy. No need to speak to bed manager. Who's the last one? Anyone? Any volunteer?
Yes.
ماشي انا هاخدها دي. حاضر. بس انا كان عندي سؤال بعد اذن حضرتك.
You can ask.
This patient, this exact patient, she was hypokalemic.
Hypokalemic. Okay, you can correct it. Okay, I think sometimes if they have hyperventilation or something, your calcium become low. Okay. So what is your opinion? You need to correct calcium or what?
Yes, no. I would ask if I'm calling the ITU or the ICU, I should mention the potassium, and should I'm gonna give the plan to correct it.
Usually it's corrected by the team for ICU or by you, but you can give the plan to correct it, no problem.
Okay.
Okay. So who needs the last case? Case 7.
Okay.
Okay. So this is again, you are Richard working with Wilberson. You call Arthur, vascular consultant in charge today to tell him a case of lower limb ischemia. 70. This is can no problem. 75 years old, chronic smoker, admit with abdominal pain, diagnosed as diverticulitis. Relieved by medical treatment. Now he is complaining of sudden acute left lower limb with a history of pain when he is walking, improve when he stops for 5 minutes. He is hypertensive on Brondobile. Brondobile is Coverseal, AC inhibitor, and has a history of atrial fibrillation, but it is not on any treatment now. Vital sign is normal, except pulse is 100, irregular. Chest and heart is normal, abdomen is lax. On examination, the left leg cold, loss of hair, decreased sensation, reduced motor power, peripheral pulsation are weak, arterial blood gas ECG is attached. And this is the file of the patient, 75 years old, chronic smoker, admit for abdominal pain, diagnosed as chronic diverticulitis, relieved by medical treatment. Now he's complaining of sudden acute lower limb pain. The pain is increased by walking, improved by stopping, 5 minutes, cramping in nature, not radiated. Past medical history, the hypertension on Brondopil, and also has a history of AF. Not in treatment. On examination, pulse 100, blood pressure 140/80, chest normal, heart examination, irregular heartbeat, abdominal normal, lax, vascular examination, lower limb, the right lower limb is normal, the left lower limb is cold, loss of hair, decreased sensation, decreased motor power, weak dorsalis pedis, and posterior tibialis. Posterior tibial. Investigation, you can find leukocytosis 26, very high. Other is normal. Urea, sodium, potassium is low. Glomerular filtration is okay, good. So it is normal kidney. Liver profile look normal. Serum lactate is 2. Arterial blood gas is acidosis. This is a picture of AF. You can see this atrial fibrillation. And this is the angio. You can see is cut here. I show you in the bar presentation again, one by one. Okay. So I just open the bar presentation. So again, you are Richard, and you call the vascular consultant. And again, you can start and okay.
Hello, I'm Richard.
Yes.
I'm working for Mr. Wolfson, and
Yes.
I'm calling to speak to Mr. Arthur, the
Yes,
vascular
I am.
consultant.
Yes, I am the Arthur, the vascular consultant in call today. Yes.
Nice to meet you. Today, my case is 75-year-old chronic smoker presented with symptoms of presented with abdominal pain and
All right. What is this patient vascular problem, doctor?
He has symptoms of acute lower limb ischemia.
Are you sure?
Left lower limb ischemia. Yes, I am sure.
How you are sure that the patient have left lower limb ischemia?
He has clinical data in form of severe pain and
No, it is not severe pain. It is claudication pain or intermittent claudication pain. And what else?
no pulse, no distal pulse.
Weak pulse or no pulse, motor power is decreased and
Is
sensation decrease and pale and cold. So in this patient, what is the causes of this obstruction? Give
can
me
be
3 causes of the obstruction.
it can be embolic or thrombotic.
No, one by one. Embolic, because why you say embolic? It is correct, but why?
Because he is known to be
If
atrial fibrillation.
okay, so this is embolus because atrial fibrillation. Why it is thrombosis?
Because it is he 75-year-old and he was old age and may have
Can have
atherosclerosis.
atherosclerosis. Okay, so can be embolus, can be thrombus, can be due to stasis or dehydration.
Yes, can be stasis or
So
dehydration.
from the script, why is the cause of this dehydration? You can see in front of you. Why this patient have dehydration?
Because of the verticulitis.
Yes, because the vasculitis can cause diarrhea or bloody diarrhea, so they have dehydration. So in this patient, we have 2 possibilities. Can be embolus, patient have AF, can be thrombosis because old age and atherosclerosis, can be dehydration due to diverticulitis. This is why we mentioned diverticulitis. Okay. Is this leg still viable or not? Or you send it to me for amputation?
Yes, it is still viable.
Why it is viable? How to know that? Because still have
Movement and sensation.
yes, okay. So is this patient fit to transfer to my unit or my hospital?
Yes,
So you transfer by ambulance. So what you give him in the ambulance?
I will put him on oxygen mask and I will start intravenous fluid and I will give him analgesics for pain.
All right, good. All right. So how quick you need to transfer? Shall I wait till tomorrow or you need to transfer today?
Urgent.
Urgent. So we called it level 1 or below code. So it is now. Is this patient have ischemic bowel?
May ischemic bowel. I cannot be sure about this.
Okay. All right. So not sure. Okay. So all right. So no ischemic bowel. Is abdominal ultrasound help to diagnose vascular occlusion or mesenteric vascular occlusion or not?
No, it needs mesenteric angiography or mesenteric Dopplers.
Don't say much explanations. No need. Okay, no need. All right. So this diverticulitis, what is effect on the blood investigation? If you remember
Because
blood investigation, what it cause?
hypokalemia because of diarrhea.
Diarrhea. Okay. Is this patient in sepsis or not in sepsis?
Uh, leukocyte is leukocyte is elevated and
So it is in severe sepsis or not in severe sepsis? What is the new marker for sepsis nowadays? What is the indicator for severity of sepsis nowadays? It is just in the last 2-3 years, they have a marker for severe sepsis. What is this?
Lactate.
Serum lactate. So in this patient, serum lactate is 2 is not much high, so this patient not in severe sepsis. Normal from 1 to 2. So this is 2 millimole. Okay. All right. If you look into ECG, this is the ECG. What's your diagnosis?
there is absent B wave, so it is AF.
How to treat it? Or how to manage?
Rate control. If the patient is stable, rate control and rhythm control. Rate control in form of beta blocker and calcium channel blockers and digoxin, and rhythm control in form of amiodarone and flecainide. and may need electrical or pharmacological cardioversion.
Okay, all right. So this is question answer. What you expected this answer? If you answer it in exam, what you expected? You take mark or no mark?
In this case, I will not.
No,
I
no.
will
If you tell this answer to me in exam, I have mark. Usually it is 1. So I give 1 or 0.
from your impression, 0.
Okay, I give you 0. So why? You expected in England, they allow you to treat a cardiac patient.
No, I will call for cardiologist.
Okay, in your country, if you work in Egypt, for example, is allow you to do that or you consult a cardiologist?
Consult cardiologist first.
So in your
Urgently.
country and in other country, you need to consult the cardiologist. So don't be so clever. This is tricky question. So the answer here, I consult the cardiologist. We don't allow the surgeon to do, in cardiology is a critical situation. Of course, your answer is correct from cardiac point of view, but from the communication point of view, you make a mistake. All right? Okay. So you understand the idea? Your answer is correct, but it is not in this position because you are not cardiologist. So you need to consult a cardiologist. If it is physiology station, they can ask you about this, no problem, because physiology need to ask you about this. All right. What else? What is the blood gases? You mentioned the blood gases. What is your diagnosis?
He has acidosis. The pH is low, and the BO2 normal, and the BAC2 normal. Bicarbonate metabolic acidosis.
Okay, correct. Okay, if you see the angio,
Uncompensated.
metabolic acidosis is okay. Not it is okay. What is the angio? What you look in the angio?
I look for the arterial system, which there is cut of the dye at the knee region of the popliteal region.
Popliteal artery. Okay, how to this patient you transfer him to me. So what you expected I do for him? Of
It
course, he
can
prepares the patient. I will ask you later about preparation, but what shall I do in my unit?
revascularization,
How to do that?
open or endovascular.
No, no, but we don't give me option. We don't have option in surgery. Just give me one. Open or what? Endovascular. What you mean by endovascular?
Endovascular in form of
Doctor, this is have obstruction. They have thrombus or embolus. First, I need to remove this embolus, so I will do embolectomy.
yes,
Followed by balloon dilatation. Followed by
stent if
buta
needed.
stent. That's it. Embolectomy, balloon dilatation, and the buta stent. Okay? But you don't tell me how to prepare this patient. Before you transfer to me, what you give this patient. You mentioned that you treat the atrial fibrillation guided by cardiologist. You correct the potassium. What else you need to give to him?
I will give analgesic for pain. I will give intravenous unfractionated heparin 5,000 unit.
Okay, all right. So heparin or low molecular weight Clexane, so can be both. So you give anticoagulant, okay, parenteral anticoagulant, and so you give anticoagulant, you give painkiller, you treat potassium, you treat metabolic acidosis. You can do all this and transfer the patient to me. Okay, you got the idea. So you need to correct everything first. So analgesic, correct hypokalemia, treat AF guided by cardiologist, anticoagulant guided by ER, if it is oral, or you can give heparin or Clexane, correct metabolic acidosis. After that, you send it to me for angio or thrombotic embolectomy. Sometimes if patient have compartment syndrome, I do fasciotomy. Okay, so it is easy, very common station. The commonest station is Oliguria. This is very common, and the cardiothoracic is very common. Okay? All right. So back again.
In this patient, should I
Yes.
mention TPA or no?